Yes, Ross, if you just press the button when you're ready. Thank you. We're live now, Chair.
Right, thank you. Welcome everybody to the Health and Wellbeing Board here at 10 AM Thursday the 11th of March. I'll bash straight on as everybody will be totally zoomed out before we know it. So, one, apologies for absence. Anybody?
Chair, we have apologies from Councillor Sanderson, Siobhan Brown, Graham Sayers.
Any from the floor? I can't see any hands or anybody else. Okay, minutes of the Health and Wellbeing Board. This was held on the 11th of February. Are they correct? And does anybody wish to bring anything up in this section that isn't already covered? I see no hands.
I would say a proposed acceptance, Chair.
Okay, that's happy with that. Seconded, anybody? Yeah, I'll second. Right, let's move on. Further disclosure of members' interests. Anybody? Cannot see any disclosures. Item 4, items for discussion. So we're going to go straight to 4.2, communications and engagement. The button order has slightly changed for those that's just joined, Ralph. So let's, Anne, over to you.
Thank you, Chair. Much appreciated. I'm not going to present this morning because I've invited Neil Caffrey along from Drummond Central, who have been leading on our Beat COVID NE campaign, and he's got some really useful information for us this morning. So I'm just going to really quickly canter through where we've been from a communications and engagement perspective. Of course, since we last met, the government have announced the roadmap, setting out the timeline for how lockdown will be eased. From a comms perspective, we've been amplifying those national messages to ensure our residents and businesses understand what all that means for them. Monday, of course, was a big step, first step in that roadmap as schools went back to face-to-face education, and we've really put a lot of effort in supporting our schools, our parents and carers and support bubbles on this. Testing has kind of grown a life of its own over the last month or so since we last met, and new testing announcements were made really on a daily basis. The most recent of which were this week, in terms of any business of any size can now order rapid testing kits for their workplace for their employees' use. And home testing kits have now been extended to nursery and early years parents as well. So put a lot of effort into that, and indeed our social media posts on testing have been one of the top posts in the last couple of weeks. As ever, we've been supporting their partners, particularly in the CCG, with their messaging around the vaccine rollout, to encourage people to be patient and wait their turn as it moves through the various cohorts. We've been continuing to support our wraparound groups with their comms and engagement activity as well, with a particular focus on education, given the schools back on Monday. We've been continuing to recruit our COVID champions, and we're really pleased with that continued rollout. They're now getting weekly newsletters, and there's a brand new SharePoint resource centre and toolkit gone live for them now, which has been really welcomed. Our regional behaviour change campaign continues, the Beat COVID NE, with messaging now updated to reflect the roadmap announcement. The focus for now remains on stay at home until the end of March, as well as avoiding household mixing. And we're also running the workplace safety campaign, which is live across all media now, including radio. We've been using Beat COVID on digital vans, which have been out and about over half term and over the last few weekends. And I think it's fair to say that, since the Prime Minister's announcement on the 22nd, more people have been out and about, and that's really challenging for us. Our coastal areas and beauty spots have been busier, albeit the majority of people are adhering to the guidance in terms of the social distancing and the hand space guidance. Like I said, that will become more challenging as the spring season continues to develop and our tourism sector starts to reopen, and we're taking a real partnership approach and working with all our partners across the county, the police, national park, tourism partners, and neighbouring authorities as well to agree a communication strategy based on the kind of key dates and timeline as outlined in the government's roadmap, and that's a real priority for us. The regional Beat COVID campaign will play a huge part in that, and we're developing that for the next kind of 5 to 6 months as we're faced with the new rules and guidance that'll follow. So our comms need to evolve to kind of facilitate the kind of safe opening of society and the economy, provide a continued regional voice of support for the vaccine, supplementing the work that's been done nationally, as I mentioned earlier, encouraging adherence to the kind of new normal behaviours, as it were, but also obviously to support businesses to be open safely and adhere to the COVID-19 secure requirements. However, it is really important in anything that we do that is based on insight and intelligence and what the data is telling us, learning from what's working and what's not, and really understanding how people are feeling about this situation and how it's the impact that it's had on them. And it's at this point that I'd like to bring in Neil Caffrey from Drummond Central, who's been leading on a whole range of behavioural insight work for us. Neil's going to provide some feedback from the phase 1 evaluation of Beat COVID NE, which will help shape what it looks like going forward, but he's also going to tell us a little about another couple of pieces he's working on in terms of vaccine hesitancy and some wider work that we've been doing specifically in a care home staff, frontline healthcare, and on teachers as well. So Neil, if you just give me a second, I am going to present on Neil's behalf whilst I bring you in. So Neil, do you want to come in at this point?
Yeah, thank you, Anne, and good morning, everyone. The initial evaluation slides that I'll show, or that Anne will show on my behalf, they are a really pared down version of the full report. So I've tried to pick out the key metrics and to keep this as focused as possible for this morning's meeting. If you go into the next page, Anne, it's useful, obviously, when we're evaluating something that we map back to our original campaign objectives. As we go through this, each of the slides with data on will have a code in the top right hand corner which just says this metric actually aligns with this objective, and then at the end I will show a table that actually presents the key metrics aligned to each objective. This is just a kind of a standard methodology for any kind of evaluation. I'm sure we're all aware of the objective, so if we move on, I'm going to talk you through the data that I'll show you this morning. And really there are 3 data sets that we're looking at. We did a baseline survey in advance of the campaign launching in December, which is to establish a benchmark for behaviour before the campaign launch, so behaviour, attitudes and perceptions of communications. Then in February we did another representative survey of the region. Some people had not seen the campaign, so we're using that as a control for any change that may have happened due to external factors. And then our third data set is people who have seen our campaign in February, and we'll look at the behavioural, attitudinal and perception and sentiment changes that we think therefore correlate with exposure to our campaign. So I will point out these 3 data points as we go through, but it's just useful to know what you're going to be looking at in the next few slides. So the first section is really just, it's good news, and our campaign has been seen as relevant, and there has been a groundswell of public support for it. So next slide. Overall, almost approaching half the region recalled or recognised our campaign. That was most prominent on TV, but actually carried through really well through the news coverage and PR and out-of-home posters and ad vans that Anne was talking about, and also through digital and social media, with radio probably being the least recognised, but that's often a feature of that media itself, because you're usually doing other things while you're listening to the radio. Interestingly, women were more likely to recognise it than men. People with children, so parents, were more likely to recognise it, and also people who are working, and particularly those in NHS or other frontline occupations, were really highly likely to have recalled the campaign. So it was recognised well across the region. It was also thought to be highly relevant. So the two red dots that you'll see in December, 55% of the region thought that the information we receive is relevant to their local area, and that jumped to 78% if you had seen our campaign in February, and actually even higher if you'd seen it on more than one channel, which is a huge leap and definitely moving in all the right directions. There was also overwhelming support for the fact that it was our councils who were delivering the campaign. So we actually asked people whether they, we told them that it was run by a partnership of 7 local councils in the northeast, and people were really glad that 82% were glad that it shows that the council's serious about fighting COVID, and those numbers go up to 84, 86 and 86% for the fact that the council's doing the campaign. The council recognises we're all trying hard, and it's good that my council is thanking people for their efforts. So there was really, really high positive sentiment about the campaign and very low negative numbers, so 5% with negative comments about the campaign, which I think is really encouraging. Not only was it supported and relevant and noticed, but actually it's a clear and easy to understand campaign. So we asked people to type in actually in the survey what the campaign was telling them. So the next slide provides really encouraging results that 93% of the people who told us what the campaign was about were able to articulate what the campaign was actually communicating. That means that you know, it's a really, really high metric. It's really encouraging that people feel like they know what the campaign is telling them. And on the next slide, we dived deeper into, well, actually, what do they take out from this? There was a really galvanizing sense to the campaign. So people were taking out messages that were commonly themed around a shared goal, a common purpose, helping the region by following guidance, and also a need to keep going and keep doing what we're doing. Additionally, over half of the people that we surveyed took out a specific social distance behavioural message, and nearly a third took out a household mixing message specifically. So again, the campaign messaging is really resonating and also is easy to understand. The upshot of that on the next slide shows that actually, when we look at people's perceptions of whether they have enough information to know what to do to keep themselves and their community safe, in December before our campaign, that number was actually pretty high already, 80%, but that has soared to 91% in February amongst people who have seen our campaign. So we've got more people now in our region feeling like they have the information they know to help them know what to do to keep safe, which again is really positive results. So that's the perceptions of the campaign. Actually, it was also a highly motivating campaign. So we'll look at a couple of stats on that too. If we look on the next slide, if we look at the green bars, there are actually 3 questions here. I know this is quite a lot of data to look at, so I'm just going to talk us through this. We asked 3 statements and asked for people to tell us whether they agreed or disagreed. So the campaign, whether it makes them want to go further to prevent the spread of COVID, whether the information they receive makes them realise they've done a lot already, that's the middle section, and on the right-hand side, being reminded that we still need to persevere to get through this crisis. And what we're seeing is numbers in December jumping for all of these metrics if you've seen our campaign in February. So 47% up to 60% for wanting to go further, 66 up to 86 for realising I've done a lot already, and 77 up to a pretty huge 92% reminding me that we need to persevere to get through the crisis. Again, I think that's highly motivating, and people are taking that message out. We also, on the next couple of slides, have been able through the campaign to reduce the doubt in the importance of the rules that we're asking people to adhere to. So the bars on these 2 slides are getting smaller as we go through time. So that's the direction we want to move in. So this is the number of people who agree that they're not convinced by the importance of the rules. So again, we've reduced the doubters from 29% in December who weren't convinced down to only 16% if you've seen our campaign. And it's a similar shape and result for household mixing on the next slide. So that was about social distancing. Household mixing's on the next slide. We see the numbers again falling from 33% not convinced in December to 17% in February if you've seen our campaign. So that is, again, good news that we're reducing that kind of sense of doubt or not understanding why it's important to actually stick to the rules that we're asking people to adhere to. So that's the sentiment, the recognition, the ease of understanding, and the kind of motivational elements. If we then try and look at behavioural change, it can be challenging to map exact causal links between communications campaign and behaviour change. We know that there's been a myriad other external factors over this period. New variants, changes to rules, testing, vaccination programs. But what we're doing is comparing behavioural data from December before the campaign with behavioural data if you've seen our campaign in February, and looking at how that correlates. So the next slide talks about the actual behavioural actions that people took when they saw the campaign. And what's really encouraging is that half of the people overall who saw our campaign remember taking at least one action as a result of seeing the campaign. The most common one is relating to addressing their own behaviour around social distancing. One of our key learnings from this question actually is that the household mixing actions were possibly not quite as high as we would have wished. They're lower than the social distancing. And that's something that we're looking to address and flex the messaging as we develop the campaign for the final stage of this phase of the campaign. The next slide also talks about how as a region, we are more compliant with the rules if we have seen the campaign. Some of these jumps are not quite as significant as the others because we're starting at relatively high numbers already. So in December, 92% of the region said they were following all of the relevant rules, either always or most of the time. That has gone up in February if you've seen our campaign. Similarly, specifically sticking to social distancing rules, that's gone up from 94% to 96% if you've seen our campaign. And sticking to household mixing rules has gone up 89% before the campaign to 97% if they've seen the campaign. So we want to see movement in that direction, and we are seeing that, and that is really encouraging that actually it is pulling through to real behaviour change. The next couple of slides are indicative as well of future change. So a good indicator of behaviour change is stated positive intent to do more. So this talks to social distancing specifically. Our positive intent as a region, actually to stick to social distancing rules, went down a little bit in February if you haven't seen the campaign, from 50 to 47%, but is 10 points higher if you have seen our campaign. So again, we're proving that the campaign is actually encouraging people to continue to want to do more. And it is a similar shape when we look at household mixing behaviour specifically on the next slide. That's gone from 46%. Just move on to the next slide, Anne. We've gone from 46% up to 52%, again, if you've seen our campaign. All of these numbers are moving exactly in the direction that we want them to, which is really encouraging. So I've got two more slides on this before I'll move on to something slightly different. Now, I appreciate this is a lot of data to look at, and you may well want to have some time to digest it after this meeting. The right-hand side of emboldened numbers is essentially showing the change in these metrics. The metrics are all mapped to the original campaign objectives. And this is a summary of what I've just taken you through, but all of these numbers have moved in the direction that we would ideally have wanted them to when we set out on our journey back in December. So in summary, on the next slide, I think these are really encouraging results. It's the midpoint evaluation, and we're continuing with our evaluation through April. We've seen our metrics moving in the desired direction across all of the original campaign objectives. So it's been remembered by approaching half the region. It's given a clear message, particularly around the importance of persevering. It's convinced people that our rules are important, and more people now think that. It's encouraged people to take action. It's persuaded them to want to do even more in the future. And we have seen our claimed behavioural adherence increase due to exposure to the campaign. So they're great, and I think that the message that I'm getting is this is great work so far, and we need to keep going, and there is appetite in the region to keep going, and an understanding of why we need to do that. So we need to keep reminding our people that they are doing the right thing, and yes, we can all still do more because we haven't beaten COVID yet.
Is that it?
That's the evaluation, yes. I have a couple of other slides to update you on 2 other strands, but I'm happy to take questions on that now if you would like.
Right, okay, I think we'll do that. I mean, the figures you're quoting are startlingly excellent. Anybody that knows campaigns, you've got to put an awful lot in. And I think, you know, the public are hungry, or 90% of the public are hungry for information, so it should be good that way. But these figures are encouraging. Let's see if I've got RC and I've got C. Is the C me or the RC? RC? That's all I can see. Andrea, can you see who's RC?
Yeah, we've got Claire Riley and David Thompson wishing to ask a question.
Claire first, I think.
I think I was the RC. So just really helpful. Thank you for that. And I think fantastic results. I think it would be really good to see some comparison to those areas that actually didn't mobilise in a way that the LA7 did. Because I'm sure that there'll be some learnings on that, and some really helpful comparator to show actually how well this has been received. So I think that's really good. I think it was really, really great to be able to see the NHS voice as part of the campaign too. So really a big thank you to Anne and Neil and the LA7 to bring the NHS voice as part of the campaign. We really do appreciate it, and I think it was an important voice to bring. Finally, just to add, just for people's awareness and understanding, is that as we start to embark on the lifting of restrictions, what we are really worried about from an NHS point of view is the increased pressures that will bring on our services, as you would expect. And I'm sure everybody is thinking that way. So just to supplement what Neil has shared, we are going to start ramping up the NHS voice around do your bit, not to access services inappropriately. You know, we're worried that people will live life to the full as the pubs open, and then we know that will have an impact in our A&E services. So it's just to let everybody aware that we are going to start to ramp up certainly our NHS voice around people making sensible choices, life choices, to make sure they don't need services off the back of their behaviours.
Okay. It looks like my name's chair's got a hand up, but it's not my hand. Is there somebody out there who?
It's David Thompson, Chair.
I thought I had a sneaky suspicion it was David. David.
Thank you, Richard. And thanks for that very comprehensive report, very encouraging one about what's happening in the county. But did you drill down, Neil, into more specific groupings to find out if within that generally positive picture there are perhaps areas where the message hasn't been getting through, you know, perhaps hard to reach groups or different age groups or different areas within the county? Because obviously it's a positive picture, but if as time moves on, you need to focus on particular groups which are not responding as well as we would want, particularly in view of the relaxing of the rules as we move forward? Was there anything more detailed in terms of specific groups of people in different places or different ages or whatever?
It's a really good question. Because the positive numbers are quite high, it's a feature of the way the survey is ran, that because the negatives are therefore quite small, that those sample sizes become very small. So when we try to then break that down even further into something like age bands, we end up working with very, very small samples that don't give us the reliability, the statistical reliability that we need. So our sample size is pretty big actually for a regional survey. It's 500 representative sample, and political polling would often be done with 1,000 nationally. So we have gone big in order to try and get a robust sample across the 7 LAs. I think the difficulty is just that when we drill down too granular, we start getting slightly, unreliable statistical numbers. I'm sorry that there's not a clearer answer there, Jeff.
No, that's fine, thank you.
Okay, as I say, I think the hard part is now coming as the weather warms up and people think they can escape out and the schools are back. So I think this is the perilous time. Right, there was 2 more slides. I can't see any more hands unless I'm missing something. Right, continue the next 2 slides.
Thank you, and I won't spend too long on these. This is really a status update on a couple of other insight strands that Anne had referred to. We've undertaken a study to focus on workers across health, care and education sectors to build on the general population residents behavioural insight work that we completed in October, November last year. We are not yet at reporting stage. We've got a first draft report coming tomorrow, but I thought I would just tell you a few of the emerging headlines from that across the 3 sectors that we're focused on. We've completed 25 one-hour-long in-depth interviews with workers and 8 stakeholder sessions across a number of local authorities in the region. Intentions are good, but there is a tension between the mental, emotional and physical fatigue that our workers are experiencing, and that is leading to occasional lapses in desired behaviours. There is also something else at play, which is a desire for social connection between colleagues, but also a desire to care. And we're talking about caring professions, and that desire can sometimes override protocols that have been put in place. Again, it's not an endemic issue, but it's something that we have found in our interviews. There are also environmental influences, so changing conditions, guidance, the physical estate, the uncontrollable environment, the buildings that people are working in, and also the links between the community and some of these settings, particularly around schools and some patients and even carers and workers' own family members are things that feel harder to control for our workers, and again actually contribute in some way to their mental well-being. But we feel there's a real communication challenge here, and that cascading information from the top down works in theory, but how much of that is actually landing with our frontline workers is questionable. We also feel that is amplified when we talk about workers on the periphery of the professions, such as auxiliary or part-time workers, who aren't necessarily always woven as tightly into the fabric of an organisation or a profession, and they don't have often the same levels of professional pride or identity driving their adherence to the behaviours that we're asking of them. And the final point that we think is that we'll expand on in the report is the need for recognition of progress and some element of incentivization or reward. being more prominent in how we communicate with our frontline workers. So this is just a snapshot of where we are just now with this work.
Okay. Any questions or further information from anybody? Liz Morgan.
Thank you. Neil, I think we were going to explore some specific issues around sort of lack of confidence in the vaccine. Are you able to feedback on any of those issues?
It will be a section in the report, Liz, yeah. If I'm being completely honest, the way that we sampled for this, which was via the local authorities themselves, we have found it very difficult to find volunteers who are refusing the vaccine to come forward and actually speak to us. And I think that is indicative of the way that they are feeling at the moment about I suppose the sense of them having potentially a bit of a target on them as you know, target audience. But we do have a section on the vaccine hesitancy and some reported issues from stakeholders. I don't have the full report in front of me, so I can't go into that right now. But like I say, we're producing a first draft for tomorrow, Liz, so it will be available very soon.
Okay, thank you very much.
Okay, anybody else? Very quiet this morning, right? Okay,
just one more for me, and then which is just another update on a separate strand of the communications work that we're embarking on, which is specifically talking to what Liz just mentioned, vaccine hesitancy. A summary of our work so far is we've been undertaking desk research, attending subgroup meetings, and have been conducting interviews with community representatives, and also with our care, our health and our education interviews that we've been doing on the other project. We have actually devised a two-tier approach to the communications for this. There will be a regional, above the line, big brand campaign that will address commonly held concerns about vaccine safety in a way that is inclusive without placing any group in the public spotlight regionally. But we will also be delivering at a community level to help target specific audiences and to use identified trusted voices within those audiences and communities to help broadcast that message within their communities, but also to help co-create and collaborate on how best to develop those resources and collateral so that it is relevant and resonant and will be listened to in their communities. So our next steps, actually, we have started developing the concepts rather than the actual individual advertising in line with our proposition for the whole project, which is together we have the power to rebuild our wounded community. And what we're doing and what we actually would like to call out today is we need to work with our LA7 stakeholders to build out who those audiences really are and to help with that below the line community level communication. And we think that this may be the ideal opportunity to connect and link in with the vaccination equity boards to start that collaboration with them on identifying audiences and establishing how we reach them.
Okay, I've got David. David?
Thank you. Just when you mentioned, Neil, about reluctance of certain people to take the vaccine, that sort of reminded me that there's some national statistics about the BAME groups, a greater reluctance to take the vaccine. I think you probably answered this actually when you mentioned specific audiences. So when you seek to approach specific audiences, would the BAME groups be within such a specific audience, because there are national statistics about resistance in that particular grouping?
Yeah, so we have actually been connecting with some community champions in the BAME communities in the region. I think that the point to be made is that this is not just about that community. This is about vaccine hesitancy, but at the minute we're planning on how we engage with various communities from a BAME background through the community champions. But we know that it's not just that, it's also care workers, health workers, and we seek data and insight from around the LA7 to help us to define more of those target audiences. And yeah, we are seeking collaboration on that.
Okay,
Thank you. Claire Riley.
Thanks, Chair. I'm just making sure people will be aware that Newcastle hospitals are the vaccine leads for our region. I'm just wondering whether or not Newcastle hospitals are involved in this comms development work and the insight work.
I don't know who can answer that. Neil?
So far, I don't believe we've had a consultation with them. We have it on our agenda to talk tomorrow in our LA7 weekly status. What action would you recommend on that, Claire? And
I think we just need to be really tight on this, because what we don't want is conflicting messages from this side through to what's happening on the NHS side. So I think it's really, really important that there's a conversation takes place with the comms leads at Newcastle hospitals, because obviously there's the NHS route coming down, and alignment is absolutely critical, especially in this difficult area.
Okay, I think that's noted. I'll go to Liz Morgan.
So just on that point, Neil, are you linked into Caroline Latter?
I have to say that if I had a colleague on, they might be able to answer that in terms of who we have currently engaged with. Anne, you've got your hand up. I don't know if you can answer that question.
Anybody?
So Caroline is the sort of vaccination comms lead who works very closely with the vaccination group, so the SFOC in Newcastle hospitals. I'm sure there will be a link there.
I've noted that, Liz, and I'm going to get an update from the team here.
Yeah, so actually, Anne's just said that Caroline Latter is linked in. She can't get herself off mute. So I think the other points that I was just going to bring up was that the BAME community is not just a sort of homogenous group of individuals, and actually within that group there are quite significant differences between, you know, the uptake of, for instance, Bangladeshi versus Indian communities. So we just need to be sort of sensitive to that. And I think the other thing I was going to ask Neil was, I think looking forward, when we're starting to vaccinate people under the age of 50, we know that working age men, particularly working age men from deprived populations, are less likely and less able to access healthcare, of which obviously the vaccination programme is a part. And so we just need to sort of try and disentangle the sort of structural issues which contribute to vaccine hesitancy from the sort of cultural issues.
Right, I've got Pamela Travers. Have you got your hand up?
Hi, I put my hand up just about the comms. I'm aware that the comms teams do have a regular meet around the vaccinations. Just that was all it was about.
Okay. Right, so we're on about the people who won't or don't believe in the vaccine. I've just seen something pop up on the news about something that's happening in Denmark, so I think that needs to be looked at. Anne?
I'm just checking you can hear me now. Apologies, I'm having issues.
Continue, or you want to speak?
Yeah, can you hear me?
Yeah.
Sorry, just to provide some assurance around the regional vaccine team. they are of course linked into this work. Neil might not be familiar with some of the names, but the others are. So just rest assured that that's all happening through Julie Mars and Marsh and Caroline Latta as well. And just to pick up on David's point in terms of BAME, actually this initial piece of work was focused around BAME and some of the harder to reach groups as well. But as Neil has said, we're casting that net a little bit wider in terms of others that we're aware are hesitant to the vaccine, including younger females around to address fertility issues and some of the like working age males, that type of stuff as well. So it encompasses all of those as far as we can. And I think just to make the point around the kind of trusted voices as part of this vaccine hesitancy campaign, it's worked really well for us through Beat COVID Any, as Claire mentioned, through the NHS. That was really important for us. But across, we use lots of diarists to tell their stories through the first part of the campaign, and they've continued to do that throughout. So that's really, really important that we follow those journeys for the vaccine hesitancy stuff, so that we can understand what the issues are, break down those barriers and get people to talk about them as well, to encourage others to take it up, basically.
Yeah, the internet is a fantastic tool for getting information out, but it also has a dark side where I know Councillor Jones and myself are in receipt of an email from someone well known in this sort of field who, well, I'll not say what it says because it would have set half the people on this call. Anybody else? I cannot see. Anne is an old hand, I think. Sorry, I shouldn't say old hand, that's the wrong word.
Mine's a legacy hand.
Yes.
I just wanted to thank Neil and the team at Drummond Central for all the work that they've done on this. This is a really, really important piece of work. As a kind of true marketer, this is where my heart sits in terms of insight-led campaigns, make sure that we get it right, understand how people are feeling, and the next 5-6 months are incredibly important for us as a local authority as we reopen our county and our economy, and we need to use that insight and data and that intelligence to shape what we do going forward.
Okay, Susan Dungworth, I wondered where you were.
Yeah, just like to keep you on your toes. It's just, I think, just backing up what everybody else has said about the very clear, consistent message, and how helpful that is to have it wider than a local authority area, because wherever people are going, they're getting the same message, and also understanding that people are working together on this. A few of you will know I'm having to spend quite a bit of time in Teesside at the moment, looking after my parents, and it's anecdotal, but what I see would suggest that people are much better up here in recognising what it is they need to do and adhering to the rules than they are there. And I think some of that is about a confusion of messages that there's been around the different local authorities in Teesside. There has not been the same joint approach, and it shows in behaviours and understanding. You know, even family members are here saying and doing things that are quite frankly wrong and they shouldn't be doing. But that's about the lack of clear, consistent message. And I think we've done it from the beginning. I think that's the other thing. I think our campaign might have got a bit slicker, but actually the messaging has been very clear, very concise, very united from day one. So thank you.
Anne, do you want to come back on that?
Yeah, thank you for that, Councillor Dunmoth. It is a really important point, and actually we have spoken to a couple of the other areas down in Teesside, Stockton. I remember presenting our initial proposal to them and they were really interested in what we were doing. And I think some of the work that Neil was talked about before in terms of understanding care home workers, frontline healthcare teachers, that is across the LE12. So perhaps on the back of that, on the back of some of the evaluation of the first phase of the campaign, we perhaps get back in contact with some of our colleagues across Teesside to see if that's something that they want to build on, because you know, we go in and out of each other's areas as you do to look after your family. So it's a really important point. So I'll take that as an action, Andrea, if you can note that down.
Right, I want to move on. Thank you for all the contributions in this report. I think the test is now on us as the nights draw out and people feel as if it's all over, but it's not, as we know. So thank you for all of that. We'll go back to 4.1. I'll go to Liz Morgan, report of the Director, Adult Social Children's Services, update on COVID-19. Liz, I presume this is you?
It is. Thank you very much. So can everybody see the presentation?
Yes.
Great. Okay, so I'll just quickly whiz through this. So just firstly, just to sort of focus on the key data and the developments. And from a national perspective, what we're seeing is that case rates are falling. They're not falling quite as rapidly as they were before, but they are generally, in terms of case rates, falling. You know, they're all going in the right direction, which is really good news. Across the 7 local authorities, you know, we're all following a similar pattern and converging at a fairly low level of case rates relatively to where we've been before, but actually still quite high case rates compared to where we were sort of last October, sort of August, September time. So we've done really well. Our communities have done fantastically well in complying with the restrictions and with all and with all of the guidance. And obviously the vaccination programme has contributed to that as well. From a Northumberland perspective, again, you know, it's all looking very positive, and I always refer back to where we were at the beginning of January, where we had, you know, we were seeing 1,200 cases a week, and our rates were, you know, probably 6 times higher than they are here. And you can see that, you know, across the geography of Northumberland, most areas or most wards have got really low levels, and the yeah, we have got a couple of wards with a few, you know, with a few cases, but actually you can see there that whereas in January some of the wards had between 60 and 70 cases, now the majority have less than a couple of handfuls, which is, you know, which is really good news. And then comparing age bands, again, we can see that the case rates are reducing across all age bands, particularly in the over 80s and the over 60s. And actually it's quite startling, the reduction in the case rates in the over 80s. They've reduced by about 85% over the last sort of 5 or 6 weeks. And clearly the vaccine is having an impact there, which is, you know, again, really good news. I think when you drill down in the under 25s, there is a sort of teenage cohort between the 13 to 17-year-olds where we're not getting as much traction, and we probably just need to drill down into that a little bit further and to see what we can do in that particular age group. But actually, you know, generally all positive. And I've put this in because this is the Google Community Mobility Report, and it looks at the movement of people, and it benchmarks that movement against the first few weeks of last year, so before the pandemic really took off. And you can see here that our use of the activities that we can engage in, so, you know, going to the supermarket, going to food warehouses, farmers markets, etc., that's sort of gradually increased. So actually we're using those facilities almost as much as we were at the beginning of last year, and certainly for parks and outdoor facilities, we're actually using those more than we were at the beginning of last year. And obviously the weather has got a bit to do with that. But looking at the bottom one where we've been using parks, you can see where those peaks are that relate to certainly to half-term weekends and weekends where we've had good weather. But fortunately, all of those outdoor activities present a relatively low risk. In terms of outbreaks and incidents, it really has settled over the last few weeks. We're getting much fewer incidents in care homes and care settings notified to us now. The number of care home outbreaks that we're actively looking after has reduced to just a couple. In educational settings, we're seeing cases really reducing significantly, certainly since the peak. Obviously, we're doing a lot of testing in schools now, and at the moment, we're getting about 1 in 1,000 tests in school-aged children coming back as positive, which is quite a low rate. So that's asymptomatic testing as part of that school's testing programme. And again, we're getting relatively few cases in workplaces, but largely we're able to pick those up through the data that we're getting through from the contact tracing service. So obviously case rates are only part of the picture, and they're, the number of cases that are actually being diagnosed is just the tip of the iceberg. But we have got a couple of studies ongoing which tell us what the actual prevalence of infection is in our communities. So this is the number of people who have infection at any one time, as opposed to the number of people that are actually being tested as positive. And the data at the top of this slide is from the REACT study, which is a study which is being done by Imperial College in London. And that's showing that the prevalence of infection in our communities, or in the communities in England, is really dropping substantially. So it's dropped from 1 in 63 to 1 in 204 between that 2.5-week period in January and the same period in February. But there is actually quite a bit of regional variation. So in the southwest, where case rates have been traditionally very low, the prevalence is much lower, so only about 1 in 434 people have got infection, whereas actually the prevalence of infection in the north is much higher, which is, I guess, what we would expect to see. But I think what this report does show is that in some regions, particularly London and the South East, there is a suggestion that the rate of increase has slowed, is levelling out, and in some places there's actually there's a suggestion that it's actually increasing. So obviously those areas of London will need to keep a close eye on those figures just to see what's going on there. And again, probably useful just to highlight the difference in experience of COVID-19 between our most deprived and least deprived communities. So in our least deprived communities, this is across England, only about 1 in 434 people are infected, whereas in our most deprived communities, about 1 in 117 people are infected at any one time, or have infection at any one time. And then the second study is the Ons Prevalence Study, which uses a different methodology, but is basically looking at the same thing. And again, identifying that the amount of infection in our communities is reducing. So that study suggests it's gone from 1 in 145 to 1 in 220. And again, a bit of regional variation, bit of uncertainty about the decline in the northeast, but we have to view those figures with a bit of caution, because it may well be that actually the number of people tested was relatively small. But I think the key messages are that the prevalence remains relatively high. The rate of decline has slowed, and there are some pockets of growth, particularly in London and the southeast. And I think what this, what those two studies do identify is the gap between the number of cases that we're actually identifying and the number of cases that are actually in the community at any one time. So for Northumberland, our case detection rate, so the number of cases that we were actually finding, was about 55 per 100,000 in March. But looking at those studies, the prevalence in the northeast up to the end of February, or up to that third week in February, was about 690 per 100,000. And I appreciate that they're slightly different weeks, but I suppose what the point I'm trying to get across is that the number of cases that we're actually finding is a really small proportion of the number of cases that are out there. So we're still not detecting even all of the symptomatic cases, let alone the asymptomatic cases. So absolutely no reason for complacency. I've put this slide in just for completeness, because obviously the announcement about the roadmap out of lockdown was announced quite a few weeks ago now, but I thought it useful to just summarise that as part of this presentation, because obviously it is going to drive how we use the outbreak control plan, how we amend the outbreak control plan going forward. But I'm not going to go into too much detail about that. I think one of the things that is expanding at quite a rate is the asymptomatic testing, and I think there is a clear direction of travel to embed asymptomatic testing as a routine part of our daily activities. And the intention is that there will be a whole range of mechanisms for people to access asymptomatic testing. So we've already got the regular testing within schools, in school staff, within household bubbles and households. We've got home testing available for some school staff. We've got employer-led testing. We've got our own asymptomatic testing sites, and we're also being encouraged to develop some community collect sites, and actually those are already in place to a certain extent. I'll go into talk about those in a little bit more detail later when we talk about the plan. And then just a bit about vaccine effectiveness. So we've had much more real-time data available now to look at how effective this vaccine is in the real world, and we can see that actually it is really effective in older age groups in reducing infection, reducing admissions to hospital, and reducing deaths. And then again, just in case this hasn't come across your desks, the JCVI have put out a statement on the prioritisation for people who are going to be vaccinated as part of the sort of second phase of the programme. So this is the rest of the population under the age of 50 and above the minimum age for vaccination. And basically what they've said is that actually the most efficient and effective way of continuing the vaccination programme is just to focus it on an age-based process and just go down through the ages. The argument is that actually if we try and pick off those groups, maybe occupational groups or people with a particular ethnic background, actually the process of trying to identify those people will actually potentially hold up the programme, and you might get there quicker if we just use an age-based mechanism to get people vaccinated. And then the next few slides are just focusing on our outbreak prevention and control plan. And I've talked about the school testing, and talked about that in her presentation. I think the feedback that I had this morning was that every school is now fully open. All the year groups are in today. The testing has gone down really well. The schools are calm, they're quiet, and I think they're just really happy to have children back in at school. I think parents seem to be confident in the safety of their children at school, and certainly we're seeing a very modest number of cases coming up in the school environment. And this just gives you a summary really of the testing programs that are in place at the moment. But it is becoming sort of embedded in our daily routines now. Targeted community testing, so we are expanding that at a rate of knots. So we've got the original testing site, asymptomatic testing sites that we set up in Hexham, Berwick, Alnwick and Ashington. We're testing fire and rescue staff, we're testing our own staff at the Stakeford depot. We've got a number of alternative education providers who are also testing their students, and we're looking at how we can accommodate the community collect model as part of our testing plans. And then the other thing to talk about really is the refresh of the Outbreak Prevention and Control Plan. So all local authorities have been told that they need to refresh that plan, and actually looking at ours, you know, there are a lot of things that we're now doing now that aren't reflected in the plan. So we've got a vaccination programme, we've got asymptomatic testing, you know, we've got experience of surge testing in response to community outbreaks. But moving forward, we need to revise the plan to take into consideration things like surge testing, how we would manage variants of concern, how we're going to manage the vaccination programme going forward, how we're going to manage the inequalities in vaccination uptake, because we do need to make sure that the vaccination programme is fair and equitable. So so all of these things need to be incorporated into the new plan. Unfortunately, the plan has got to be submitted, or a draft of the plan has got to be submitted by Monday, but the refresh of the contain framework on which it's based isn't going to come out for another couple of weeks. But we're currently working on that refresh at the moment through the work of the Health Protection Board, and we'll bring the most recent draft, or the draft that we submit, to the Health and Wellbeing Board next month, so that you can comment on that and just make sure that we haven't missed anything. But I think what they particularly wanted us to include was some feedback to them really about good practice issues, risks and opportunities. So from a good practice point of view, they really wanted us to tell them what worked well, what we'll maintain, what areas have been most critical to the response and have worked best and why. They want us to talk about and feedback on some of the issues. So was the plan deployed as designed, and if not, why not? Where are the gaps and have they been resolved? What areas have been the most critical to the response, and which ones have failed to be as effective and why? And then something about what national initiatives here have been less helpful. And then from a risk perspective, they've asked for feedback on the factors that could impact on the ability to deliver the outbreak control plan, and how have we mitigated those risks, and what are the most probable risks and what would their impact be. And actually we have developed a separate risk register for the outbreak control plan. And then the last thing was about opportunities. So what aspects of the national, regional and local response, if we started them, stopped them or changed them, would have the most significant impact on local response effectiveness. And so on this slide, we've just tried to, as a health protection board, fill in those particular areas. But I think if members of the board have got comments that they'd want to include in that feedback, we'd be very happy to take that and include that in our response.
Right.
And then, sorry, I've just got 4 more slides which I'll just whiz through. So these are the updates on the wraparound groups. I think from a care home perspective, it's all very quiet. As I said before, the number of outbreaks in care homes has reduced significantly. I think we only had, in the 7 days up until Tuesday, we only had 4 cases identified in care settings, and actually, a month previously we'd had 16. So still really quiet from a care homes perspective. From an educational settings point of view, and I've obviously talked about a lot of those issues around testing, and I think the education group is working particularly well. And the questions we're getting through at the moment are about confirmatory PCR testing and the need for that. But actually, I think the schools have responded really, really well to the ask that has been put on them around testing. I think the workplaces and businesses, this is the area which is going to generate the most activity over the next few weeks, and we're starting a lot of work with businesses just to make sure that they are as COVID secure, prepared as possible. And I think there's a whole raft of guidance that is going to come out over the next few weeks. But of course, the regulations probably aren't going to come out for a couple of weeks. And until we see the regulations, it's a bit difficult to advise businesses on any additional COVID secure actions that they need to put in place. And then the high risk individuals, communities and settings group. This is a really well attended network. Again, no real issues, but I think we are, constantly in communication with these particular groups just to make sure that we are protecting these most vulnerable people in our communities as much as we can. And then I think, the final slide is really just about some key messages. I think it just, highlights the importance of continuing with the measures that we've been taking for the last few months. The vaccination has obviously made a huge difference, but we still need to keep on with those behaviours around hand washing, wearing face covers, and maintaining that social distance. And I think we just need to encourage people to maintain those behaviours for a bit longer, and try to resist the temptation to stretch the envelope in terms of the relaxation of restrictions. So we'll obviously be looking closely at the data once those restrictions start to be relaxed. That's pretty much finishes my presentation, right, Chair, but very happy to take any.
I'm sure Andrea will forward on those presentations, the early ones, and yours, Liz, because I lost some of them at the end, or didn't appear on my screen.
Okay.
Right, any questions? I know time is... Susan.
Thank you. It's what we know, isn't it, about this disease affecting people more in terms of deprivation. So what the pandemic has done is highlight that. And I suppose my question to this group of professionals is what we're going to do about that, because health inequalities will continue when it's not about COVID. And what have we learned, and what actions are we thinking about doing to ensure that we don't continue with this level of health inequality?
Liz?
So, oh yes, sorry, I just put my hand up. So yes, I mean, I think what this, as you say, what COVID-19 has done has just re-emphasised the structural inequalities that exist amongst our communities. And one of the things that we could do is a community impact assessment to really look at what the impact has been on our communities, focusing on the wider determinants, and use that as the basis to drive our recovery programme. I think doing any sort of community impact assessment before now would have been probably really difficult to do, because we probably wouldn't have had the data there to actually drill down and find out the extent of those inequalities and how they have been exacerbated. But I think that would be my recommendation in terms of a way of just using that to focus our activities in a way which is going to mitigate against those issues.
I'm sure that when we get to the, getting this really stamped down, that will be a big discussion. Jeffrey Watson.
Oh, sorry, Chair, can I come back? Can I ask that we do take that forward as an action from this group, or else this group just is pointless. It is just a talking shop. So, it's been suggested that that's a way forward.
Yeah, I'm sure we can note that and include that, Susan. It might not be my job.
No, but you could leave a legacy, couldn't you, Richard?
I always try to. Jeffrey Watson.
Yeah, just a question. Please don't misunderstand the question. I'm not being dismissive in any way, shape or form, but we're starting to have long-term future discussions within the group of people that I speak to about what's going to happen in the future. And we often talk about the prevalence of flu virus in the community. And what sort of level that the COVID will go to. Will it be the same level as flu or what have you? And I wonder if we knew roughly what the level of the flu virus in the community was. And is it fair in any way to compare the two, do you think, to say that in the future COVID will be another flu? I mean, I've heard that from so many different people. So I don't want a long answer because I know we're running out of time, but a short answer from someone would be very interesting.
Right, Liz Morgan, I know you've got a hand up. I've got Jane. Liz?
So I think they're probably quite different infections, but in some ways they are related, because obviously all of the behaviours that prevent COVID-19 also prevent flu, and that's part of the reason I think why we've had so little flu activity over the winter, which is probably a good thing. But they are quite different infections. But obviously we do have a flu vaccination programme, and I guess we're just waiting for a bit more clarity about what the sort of long-term plan is to prevent COVID-19, because obviously as years progress there will be people who get to a certain age and can have the vaccine, and it may be that coronavirus becomes just a routine vaccination program, but I don't think we've established what that's going to look like yet. But Jane may have a view.
Jane?
I don't really have. I had another comment, but thank you, Liz. It's just, I think it's impossible at the moment medically to say where this will land, because we are not, as Liz says, we've had virtually no identifiable flu this year. So what we must assume is that the disease that we've been seeing is very much more transmissible and is a different disease. It's not just a respiratory illness, which flu is. It's a very much more dangerous disease, and there's an awful lot of the medical side we don't know. So I think it's about containing, and it's really good that we've all putting out the same message, trying to help people understand how they should behave. Chair, I've just got one comment. Add in one comment about the vaccination programme. I took this from the COVID Health Protection Board, which I sit on as part of the LMC, just to say we've heard an awful lot about the strain and stress on our secondary care colleagues, but I'm sure John would join me in saying that we want to make this board aware that we know that you've thanked our primary care colleagues, but they are continuing now. This is a marathon that they're running on the vaccination programme, and at the same time, contractually, from the beginning of April, they're going to be required to do business as usual as well. The vagaries of the national booking system, as those of you who've tried to book a vaccine through it, are such that it's causing absolute mayhem. So we would be very, very grateful for any support to say that actually the primary care is working very hard in Northumberland without, at the moment, mass vaccination sites to deliver the programme, and, you know, obviously to help us support our primary care colleagues who are going forward into a very difficult time. And the other thing I just wanted to say, there will be debates, and Liz has backed me in saying this, about producing a collaborative working to deliver between our hospitals, our Newcastle hospitals who are the lead, and pharmacy colleagues and primary care to deliver this mass vaccination programme going forward. At the moment, we're being stymied by red tape at the centre, but I mean, I won't bore you with all the details, but just to say it will probably be next month that we'll be asking for more support on bringing forward a collaborative arrangement for all the vaccination for all our population. Thank you very much, Chair.
Thank you, James. Well noted. I think I've got David Thompson hand.
Yeah, thank you, Richard. Very, very quickly, just from a Health Watch Northumberland perspective. A lot of calls, I think about 4,000 views of its website on the vaccination programme, etc. The vast majority have been just asking simple questions, you know, why, 12-week wait between them and so on, who do I phone? But there have been within this a very, very small number, as has been mentioned before, of people having real difficulties accessing a site for vaccination because of where they live or because of lack of personal transport, etc. In the context of this, it's a very, very small number. And I think that reflects on the astonishing work which everyone collectively has done, as Jane has just mentioned there about the GPs, etc. But it's a small number, a very small number in the scale of things. But for each individual, it's quite a challenge and a worry. And the information has been passed on to, you know, the CCG and wherever, and I'm sure action will be taken. So it's a generally positive response from the people who've contacted Health Watch, but that small number, very small number, who still have access to their vaccination site. That's the only significant issue, small though it may have been in numbers.
Okay, point noted. I'm hearing nothing but praise of everybody that's had an injection of the sites and the way they're managed, they're in, they're out. Councillor Jones.
Yes, Councillor Dodd. I'm sorry, it was just really to give my apologies. I have another meeting coming up. I didn't want to just disappear, so I'll just say thank you.
Right, fine. I think we all have meetings coming up. Susan, I will make sure we're coming to the work plan. So I'll make sure that we have what you request on the paper. Liz?
We've got Rachel here who's geared up to give a specific update on the vaccination programme.
Okay, right, Rachel.
And Councillor Dodd, I don't know whether you want to hand over the chair if you have another meeting to go to.
I'll persevere.
Okay, right, Rachel, I'll try and load your presentation.
Thanks, Liz.
This is where the adventure continues.
I do have another meeting, but Councillor Jones will be able to cover at that meeting. We have agreed that what would happen. Right, Rachel, is this your show?
This is my show, and I'll try and keep it as quick as I can for you. So the message from the vaccination team still remains the same. Please wait your turn, be patient, and you will be contacted for your vaccination. I've got some numbers for you just so you can see the progress. So we're on week 13, which is quite incredible. I feel like I've been doing this for a long time, and certainly across the North East and Yorkshire, we've got 2,666,000 people now vaccinated with their first dose, which is about 40% of their population. And in starting second doses, about 100,000 having their second doses. 94% care home residents, 77 staff, and 91% with clinically vulnerable population. And then that little pie chart there just shows, and as Jane's just mentioned, the bulk of this programme being delivered, 65% from primary care and local vaccination services, 25% from the mass sites, and the remaining bit from hospitals and community pharmacy. A little bit more local across the North East and Cumbria, we've got 954,000, which is about 39% of the population, and about 36,000 second doses. And then in Northumberland, 113,574 people with the first dose, which is 42% of the eligible population. So performance really strong in Northumberland, and 3,500 second doses, which we started early March. And there you've got a number of those vaccinated over 65%, which is at about 93%. We continue to obviously cover the most at-risk cohorts, so you can see you'll be probably quite familiar with that, and we are looking to a deadline of the 15th of April to have got down to the cohorts 5 and 9, and actually the whole programme due to finish by the end of July, second doses as well for all those cohorts. So primary care is, as you know, we've got our 10 sites across Northumberland, so yes, and it's still very challenging. We still I have sort of a push model for supply, which does make planning quite difficult. But having some AstraZeneca is helping some flexibility. So from a point of view of more local people being able to be vaccinated, some of that is now out to individual practices as well, which is helpful. Just an update on the transport that David mentioned, just as we did commission Age UK to help support, and this just gives you an idea of the numbers. So 312 journeys helping 156 patients, and these are offers when people are called for their vaccines. So this is just, I think, from the end of February, so we'll get some more data on that as well as we go. But we do keep pushing it with the practices and reminding them that that service is available. The hospital hubs are beginning to deliver their second doses. They obviously did include some patients, some outpatients and ward patients within the over 80s mostly, though they did the health and social care staff. And they've also picked up some of those patients who required to be vaccinated in hospital due to their sort of medical condition around anaphylaxis. So we continue to work closely with the hospitals, and they are certainly picking up on their second doses now for the staff groups. Our nearest sort of mass vaccination site is the Centre for Life, which a lot of people are still using, and the national letters, as Jane alluded to, are going out very fast. We don't have any control over that. It is very nationally controlled, and of course once somebody has a letter, they're very keen to get an appointment. Our message is that they can go to mass vaccination sites. They're all available on the online booking. However, if people do wait, primary care will also get to them if they would choose to have a more local appointment. We are working closely with a community pharmacy and getting community pharmacies on board with this, which will also help to increase the capacity. They would be looking to deliver from sites about 400 to 1,000 doses a week, and we're really promoting a collaborative approach with primary care and community pharmacies. So we don't want them working in competition, but very much working together, and that's been really positively received across Northumberland. Just to give you a little bit of an idea of the supply for the next few weeks, you can see a really big increase there. So this is the sort of supply coming into Northumberland. So from the 1st of March we had sort of over 7,000, 8th of March week 8,000, and then the 15th 21,740 available vaccines, and then we need this to be confirmed, but it's looking at about 23. So really is a big step up coming into primary care for them. Trying to get a little bit closer to more local data. This has just been nationally published data from NHS England, and this is using sort of middle layer super output areas, which is really just a geographical hierarchy, which is designed to kind of be able to let us look at where the data is and have a bit of a more local look, which is really helpful for us and for our approaches going forward. So this is just showing the percentage of 65 plus that have had at least one dose, and you can see the left column is the top 10, and the other is the bottom 10 groups. Still quite high percentages, still though. As we're trying to increase the capacity, this is our sort of proposal going forward, and certainly from that last data, if we have our roving model has now been approved, so we are looking to get that started very soon, and they will be looking to do about 500 to 1,000 vaccines a day, and this will very much support our rural areas or areas that maybe haven't had as much uptake, which we'll be able to tell now better from the data, and some of those hard to reach groups and communities. It's very much run by the PCNs, but it is a different service, but they're running it as in a collaborative way, which I think is a really positive model, particularly for the geography in Northumberland. We are looking at a vaccination centre as well, which would be able to take people from the National Booking Service, so that we could keep those people within Northumberland, and we're working with SVOC very closely around that. It's likely to be in the Hexham area, and we have got community pharmacies coming on board. So we've had 4 approved so far, which is great, and I'll just show you then on this next slide just a bit of an idea. So from a point of view of Northumberland's coverage, the little blue stars are our primary care sites. The triangular the green triangles are where we think we might use the roving model to get to those rural communities. I have to say the fire and rescue services have been really helpful in providing their buildings for us, and they're obviously very well integrated into the community, which is really good. And so some really good local working with the local authority on that. And so we probably have set sites for the roving model to get to cover our more geographically areas, and then look at working with the equity boards on the hard to reach groups. The purple flag is in Hexham, we've got to have that confirmed, but we are looking at Hexham for that. And then you can see the little yellow boxes are the pharmacies. So you can see that therefore we will have ability to vaccinate more people in order to meet the target of the end of July. Just briefly mentioned about the vaccine equity board, which is in place, which is helping us to identify those groups that we've already had a chat about that today, which is really important so that we can make sure we reach the right people. Just a reminder really that actually nothing greatly changes after the vaccination, and we still have to be very cautious and follow all of the recommended advice about keeping 2 meters apart, wearing the right protective equipment, and that goes for health and social care professionals as well. From a point of view of the next steps, obviously a very busy programme. We have got to have finished cohorts 5 to 9 by the 15th of April, and we're looking at targeting all eligible patients by the 31st of July. The This is all, of course, if the supplies come through. It is likely and it has been discussed around a booster maybe in the autumn to increase the resistance of all the new emerging variants. So it is likely to be a very much an ongoing programme. So that will mean that we will be looking to deliver this alongside flu, which obviously makes this very much probably several marathons from a primary care perspective for the work that they need to do. I have to say that they are brilliant, and they are very, very committed to this programme and are really working really well together as practices as well as with other partners. So just from a point of view of the future, I think we are now beginning to see some reductions in hospital admissions and deaths amongst our very elderly, which is really positive. We think it'll be another 3 to 5 months before we see significant reductions in community transmission as a result of the vaccination programme, and we're looking at that 70 to 80% of the population to be immunised for that, and of course we're at about 40 at the minute. Initial studies show that AstraZeneca vaccine has up to 67% impact on reducing transmission, and they are looking at the possibility of mixing doses, and studies are along about that, although at the minute we're still very much sticking with the same. And yeah, this key message, we are aware that it is really quite confusing for people, but you know, please encourage people to wait. They absolutely will not be missed. Thank you very much.
Right, any questions? Susan?
Yeah, just a quick one. Whenever I've gone on the system, and I've done it every day for 4 days now, for the national booking system, the only places that come up are Durham. And I'm just wondering why there always seems to be places at Durham to go and get vaccinated and not at Newcastle. Have they got through much? And it seems to me something about distribution. And again, I was anecdotally, but from family members in Teesside, they're getting sent to Durham or not, because they're not going to Durham as well. So it seems like the supply and demand isn't quite in the right place.
Thank you, Councillor Dungworth. It's difficult to be able to give you a really straight answer for that, but what we are doing is keeping an eye on where the vaccine's going, so we can see the vaccine supplies to Northumberland and to the mass vaccination sites, and the distribution is fairly even. It's not like the mass sites are getting an additional amount. I also think that obviously the Newcastle one has been up and running for a long time and people have booked in advance, whereas the Durham has come quite recently online, so I don't know whether therefore there's just more availability in Durham, whereas Newcastle has already had their slots booked up. But it's certainly one to keep an eye on as we go forward.
I'll go to Jane Lothian.
Yeah. Yes, you're quite right there. The problem is that the national letters have gone out far in advance of any sort of correlation with what's happening in primary care. Because we don't yet have a mass vaccination site in Northumberland, there's probably a bigger demand on the Centre for Life. And as Rachel said, we have absolutely, and this is something which the general public are having difficulty in understanding, because it's so unlike the flu situation. Any of the sites, the mass vaccination sites and hospitals included, have absolutely no control at the moment over what their deliveries are. Absolutely nothing. So it's not that the GPs and the mass vaccination sites are sitting there on fridges full of vaccine. It's coming in and being put in people's arms within a matter of hours. And likewise, I'm trying to put my own vaccination, and I haven't got anywhere closer than Durham yet. So, but anyway, but as I said before, it's about this group trying to appreciate and support the message that at the moment it's beyond our control. We're doing absolutely everything to try and influence the situation, but it's baby steps at the moment, Councillor Dungworth. It really is baby steps, but we're getting there.
Right, Jeffrey Watson.
Thank you, Chair. Rachel, those figures are very good, in most cases very, very positive. But I did have an alarm bells with one figure I saw, and I wonder if you can do anything about it. 77% of care home staff are vaccinated. That's a huge number of people in care homes who are not vaccinated. Is this an ongoing problem? I know it has been a problem, but is this a problem that we're not be able to get to grips with?
Actually, that data is across the North East and Yorkshire, and I probably could get you a more up-to-date number for Northumberland, but we have certainly a higher percentage in Northumberland than they do across the North East and Yorkshire. It's just having access to the data. We kind of really struggle with that, but I think we are tracking that, and I think it is higher, but I will definitely look into that, and I'll make sure I share that with you. We are constantly working with the care homes and encouraging them to take up their vaccination programme, and I think as primary care go back into the care homes again for the second doses is another opportunity to make sure and check on staff where they are. I think equally the care homes have had a number of outbreaks, so when the first doses went out, some of them weren't able to be vaccinated because they were quite close to their recovery from COVID themselves. But I will get that number because I'm fairly sure it's higher than that.
Okay. Jane, is that a new hand or an old hand? Jane?
Yeah, just very, very briefly to say that, yes, it is a worry, but Anne, all the work that Anne Bridges has been doing and her team is to try and address this, because what we've got to realise is that the staff in care homes are by and large quite a young population in whom there is a large amount of vaccine hesitancy. So please be reassured that everything is being done to try and persuade them to be vaccinated, and the situation is improving all the time.
Okay, right. I see no other hands. I think we thank everybody for their contributions on that one, Rachel. I'll go on to the forward plan. I'll just need to note that the next meeting on the 8th of April, we will be in Perda. So that might be an advantage or a disadvantage, but I think we'll have to think about that one because obviously we need to keep on going with the messages, etc. So that's that one. Item 6, urgent business. I have none. Susan,
yeah,
got you.
Thanks. There is no reason why the business of the council and our partners shouldn't continue in Perda. Perda only affects the publicising of individuals or political parties. So
I know, but I just...
It's irrelevant.
Well, irrelevant. We're in Perda, which means we can't be put out to be saying, you and I can't be quoted.
Well, we can be, so long as it's
yeah.
not in terms of politics. We absolutely can be. We are still councillors, and the business of council continues until the 6th of May.
Right. Okay. Ralph?
Yes, I asked if I could just raise an issue that has come up from meetings that Maggie and I have been holding as the
yes,
BCS.
I did agree.
Yeah. And that we've been meeting with, there's about 100 organisations in the county who see themselves as being concerned with health and social care, and we've been having meetings with them, not all of them obviously coming, but they wanted to share with you what is their unanimous view about the biggest need for the people using their services, and that's about social isolation. And the impact of that on their well-being. And it fits in a lot with what we've been talking about, which is about the reopening and the concern which there is about people going too far. But the concern in this instance is about people not being able to re-engage. For example, one telephone friendship line had 95 members of it at the beginning of the pandemic, and has now got over 325 members. And the concern is being able to reach these people and having the capacity to reach these people. So they wanted to share with you about the need for practical support to meet this expanded need and the threats that it brings to people's well-being. This obviously includes issues of funding, but it's also issues about sharing ideas and plans and working together, sharing concepts to work together. So that you as statutory organisations are aware and prepared to meet future requests for support to meet people who will continue with this feeling of being very socially isolated. Thank you.
Right, Liz, do you want to comment on that, or shall we put that in the box and bring it back on Ralph's concerns? Liz?
Thank you. I mean, I think if we're going to go ahead with a community impact assessment, one of the things that I would want to explore would be issues around social networks and social isolation. So I think there's an opportunity to certainly explore it in a bit more depth as part of that process.
Yes.
Okay. I think we'll make a note of that and we will come to it because it would be valuable.
Thank you.
Is that fair? Right. Urgent business. I have nothing. Nobody. I've got Ralph's hand, but I presume that's an old hand. Date of next meeting. Date of next meeting will be held on Thursday, the 8th of April in Perda, but we'll still have the meeting. And we can say what we want, Susan. Thank you. Thank you all for your attendance, and let's see what this next 4 weeks bring. Hopefully more good news. Okay, thank you very much.
Thank you.